hello and welcome to Healthline. I'm Jennifer Blomquist. I have the privilege of hosting the program this evening, and I'm so glad you joined us. We have one of our returning guests. He's been coming here off and on for many years. So it's Dr. Micah Smith, who is an orthopedic surgeon, and he is here to answer your questions, give you some free advice. Maybe it's a question you have about yourself, or maybe it's about a loved one or a friend. Please give us a call. That's why we keep that phone number up at the bottom of the screen throughout the show. So it's 969-2720. In case you're outside of Fort Wayne, it is a toll-free call. Just put an 866 in front of there and we will get you through. And you have two options when you call in. My favorite one is if you call and ask the question live. And what's nice about that is that Dr. Smith can converse with you. Maybe he needs to get more information from you to give you a better answer. So that one's great, but I completely understand if you would prefer to just call in the question and I can relay it to the doctor. That's another option you have as well. So please give us a call. Again, we keep that number for you up at the bottom of the screen. So let's go ahead and you can see Dr. Smith again, Dr. Micah Smith, and you came with props, which
Absolutely.
It's always helpful when you bring the spine, I think.
Definitely.
We are going to talk about a bunch of different surgeries, but please feel free to interrupt us. Maybe your question isn't exactly what we're talking about at that specific moment, but that is fine. Please call anyway, and then we'll get your question answered. So, I know one of the things we wanted to talk about was cervical and lumbar disc replacement. So I don't know if you want to talk about that. I think a lot of people they've heard of the terms, a slip disc, herniated disc. So is that, if you're dealing with an issue like that, is that why you're going to need disc replacement? Or?
Yeah, so typically somebody who has has an issue with the disc, you start to get wear and tear, just like in your cars, okay? And the disc is like the pad, the gel pad in between all the different vertebrae, each of the individual pieces of the spine. And as the disc wears out, the area where the nerve comes out, that area gets smaller. And so if the nerve's coming out like this and comes through the hole between the vertebrae, now all of a sudden that area is pinching the nerve. And so people start getting pain in the neck, they start getting pain and numbness going down their arm. It's extremely uncomfortable. I am my own patient. I had a 2-level disc replacement about 2.5 years ago.
Wow, okay.
So I know exactly what people are going through when they're dealing with something like this. So we've had a lot of advances over the last several years in terms of the technology that we have for patients. We can do disc replacements now to where we are able to keep the motion or mobility of the spine. We're more advanced in the cervical spine than we are in the lumbar spine. Cervical spine disc replacements are becoming very, very common. When I came out into practice 12 years ago, we were very selective on who we could do a disc replacement on.
Oh, okay.
And as the technology's gotten better and our understanding and our ability to place the implants better, we're able to widen our indications. So before it was like in people that basically had a pristine spine, just a disc herniation.
Yeah.
And so we were taking out the bad disc that was pinched on the nerve, and then we're replacing it. Now we're doing disc replacements on patients who have much more arthritic spines and things like that in the neck. And it's a game changer. And I know people are
Is it instant relief after the surgery?
It is. Like when I had mine, I woke up immediately and my pain was gone.
Oh, wow.
I still had some numbness, but the pain was like immediately better.
That's always nice to hear.
Yeah. And it kind of helps, it kind of replaces that, that fear of the fusion, because we've, over the years we've done a lot of fusions in people.
Yeah.
And so now our indications are we're doing less fusions and some more disc replacements in patients. So we're able to keep the mobility of the spine and hopefully prevent the next level in their neck from breaking down and having an issue. We are doing it in the lumbar spine, much more selective. The surgery is much more technically challenging.
Okay.
There's a lot of other issues like with the blood vasculature and all that stuff around there that makes the surgery a little more challenging and less, I won't say safe, but just more challenging on our part. So we're much more selective.
So when you have a surgery like that, is there any kind of physical therapy or anything you have to do afterward, or are you on like anti-inflammatories for a while? Or
Yeah, so a lot of people, they have some pain medicine. We try to obviously get people off narcotics as soon as we can, and onto just regular anti-inflammatories or Tylenol. And then obviously the goal of surgery is to be off the medications that you're on. We do have people in physical therapy. Our practice, we usually get people in the physical therapy about 2 weeks after surgery, because now that we've done the surgery, we want to mobilize you, we want to get you back to life. That's the whole goal of surgery, right? And so then physical therapy is there to help strengthen all the muscles that have been kind of weakened with the surgery and help decrease the inflammation and start improving that mobility and everything, get you back to enjoying life.
Yeah, many of your colleagues and yourself who've come on over the years with a lot of surgeries, whether it's back, knee, a lot of times I'll hear the doctors, respond to a patient when they say, well, when do I need surgery? And the doctor will say, it's up to you, when is it impeding on your everyday, life, and get to the point where you feel like you're just not functioning,
Yeah, I tell people, you will know. Like, you can tell me, unless there's like a severe neurologic deficit or something like that, it's really, up to you when you say, I've had enough.
Because are you, especially with this, when you're replacing the disc, are you at risk if you put it off longer that other discs will be impacted, or not necessarily?
Not necessarily.
Okay.
In terms of, there's just general wear and tear that occurs. And so, putting off a surgery doesn't necessarily mean that the other ones are going to go. It's just mostly a matter of time.
All right, good to know. I'm sure some of you out there have a question. So who doesn't have back pain or knows somebody who has back pain?
Yeah.
So please don't be shy. Give us a call. That's why we keep that phone number up at the bottom of the screen throughout the program. Again, it's 969-2720. Still toll free if you're outside of Fort Wayne. Just put an 866 in front of there. I guess I also wanted to address the issue that a lot of people get nervous. They don't want surgery, but I don't know if you want to reiterate maybe some of the conservative steps that.
Yeah.
I know that you don't just throw people in surgery unless it's a dire situation.
Right.
So.
Yeah. So we have a whole kind of protocol or regimen of things that we do to obviously try to avoid surgery in patients. There's various medications. Like I said earlier, we really try to stay away from any narcotic medicines. People, especially with bad, muscle strains in the neck, in the lower back, we'll try a muscle relaxer, but even then, it's usually a temporary thing.
Yeah.
We try anti-inflammatory medicines. Some other what we call neuromodulatory medicines that help with the nerve pain and things like that, just to kind of get things to calm down. Because most part, a lot of it is, it's a process of time. There's some arthritic change or something that's happened. And, if it's just not bothering you, but 6 months ago it wasn't, the whole idea is to get you on the other side of the fence, back to where it wasn't, bothering you. So we'll do anti-inflammatory medicines and things like that. We'll try some physical therapy, improve the core strength, get your leg muscles, your pelvic muscles, your abdominal muscles, your back muscles all working together. I tell people it's kind of like a concert or an orchestra, okay? If one muscle group's more developed than the other, then they start to fight with each other. And even professional athletes. I mean, basketball players and football players do physical therapy for things. Yep. So people oftentimes don't want to go to physical therapy, but if professional athletes do, you may need it too.
Yeah, and a lot of my daughter had physical therapy, and they gave her exercises, and they said, she said, well, how long should I do those? And they said, you should do them all the time. I mean, just make it part of your everyday life,
Absolutely.
like part of your it's like part of your exercise routine, and I mean, I think it's beneficial for people.
Yeah, I see people all the time. They're months out, they're 2 years out from surgery, and they're doing great. And I just reiterate, keep up the exercises, 2, 3, 4 times a week. Keep doing them.
Yeah.
The whole goal is not to have to do this again.
Right. Yeah.
And so hopefully, if you keep up those exercises, it'll help prevent it.
Yeah, no. In the long run, if you got to look at the big picture, it'd be a good idea for sure. So, and I know another topic you wanted to discuss was minimally invasive spine surgery.
Yeah.
So we hear a lot. Is that the same as robotic surgery, or is that different?
So there's a lot of things that go into minimally invasive surgery.
Okay.
The goal of minimally invasive surgery is to decrease the trauma that occurs to the body when you have a surgery.
Yeah.
Because surgery is still just a controlled trauma to the body. It's a purposeful, it's direct, we're going to fix this problem, but the body still has to endure some trauma. And so anything we can do to kind of lessen that is, it's beneficial. So there's a lot of new techniques where we do what we call muscle sparing, muscle splitting approaches to decrease that muscle pain and things like that after surgery. There's ways that we can access different parts of the spine, especially up in the front, to where we're able to not going through the back muscles so much. And so when we're able to do that, then there's a lot less bleeding, less discomfort, and usually you can back to normal life a little bit quicker.
Okay.
So there are things, I personally use robotics. My other partners, we use navigation systems and all these other things that help us plan our surgeries more efficiently, which then decreases the trauma. So robotic surgery is just one of those tools that I use to help do minimally invasive surgery.
Yeah. No, I mean, anything you do to make it, I guess, easier on the recovery process. I'm sure a lot of people would
Absolutely.
be fans of that. So full disclosure, my eyesight's bad, so I'm going to turn here and look at the, I forgot to put my contacts in again. All right, that's another issue I have. So we did get a call, doctor, from a gentleman named Juan, and he said that he had surgery on his back, and he says his hands are always tingling and cold now, and he's wondering if that's normal.
I wouldn't say it's normal.
Okay.
But sometimes it's not necessarily related, due to the
Like
surgery.
I didn't know if it'd be like a nerve.
Yeah, so if it's
issue,
in the
but-
hands, it's either, could be a carpal tunnel,
Okay.
it could be a pinched nerve in the elbow, or it could be cervical spine related, something from the neck. So it was actually, surgery on the lower back itself. It probably has nothing to do with the actual surgery,
Okay.
other than sometimes just other things that happen, and sometimes it's just a coincidence that you may have some neck pathology that now has kind of evolved, coincidentally
All right.
around that time.
Is that would you be alarmed about that? Should he get that checked out, or is that maybe?
I think it's wise to to get checked
Okay.
out if both his hands are numb. Especially if you're having some issues with dropping things, you kind of feel clumsy with your hands. If your balance is off, then I think it's very reasonable to get checked out by one of us professionals.
Okay. All right, Juan, thank you for calling in. I appreciate it, and good luck to you. Let's see, we had another call. This is from Lois, and she said her brother is having back surgery, and they told him to stop smoking. So she was asking about, which, smoking and recovering from surgery, that probably doesn't make for a good mix.
Yeah. So the smoking issue has always been there. It's becoming a more and more issue to
Okay.
life. Really, especially the insurance companies lately are very cognizant of the issues of smoking in relation to surgery.
Oh, okay.
So in and of itself, smoking, especially if you have to have a general anesthetic, your risk for respiratory issues, pneumonias, things like that, go up, from related to smoking. Smokers have a higher risk of having a DVT, so blood clot.
Okay.
So if you have a blood clot, now you're on a blood thinner for months, and if the blood clot breaks off, it can go to your heart, lungs,
Yeah.
it can kill you.
Right.
So those are significant risks. And then specifically to spine surgery, it's the nicotine. It's not always the smoking. So
Okay.
even chewing tobacco, vaping, anything that has nicotine in it actually causes what we call vasoconstriction. So it causes the blood vessels to tighten down. And when that happens, there's less blood flow to the tissues, so there's less oxygen being delivered and less nutrients. So your risk for an infection goes way up. If it's spine surgery and you're having fusion, your risk for it to not fuse, not to heal, goes way up.
Yeah.
And so if that happens, that's when you hear of screws loosening,
Oh, gosh,
rods
yeah.
breaking, all those things that you don't want to see happen. So there's true things that are like it's a patient safety issue, and
Yeah.
we're trying to avoid complications. So it's in the patient's best interest.
Well, in general, it's just a good lifestyle change. I mean, I've never smoked, but I've heard that it's horrendously difficult to stop. So, I mean, I do sympathize. It's especially if you're somebody who's been doing it for a really long time.
Right.
But I can understand that. I didn't realize it was an issue with the insurance companies either. That
Yeah, so a lot
starting.
of their insurance companies now are being very protective of the cost for surgeries, and so
yeah.
if there is a modifiable risk factor, then we want
Okay.
to try to work on that.
Yeah.
It's just like patients who are diabetic. If their
Sure.
blood sugars are uncontrolled and their hemoglobin A1C is very high,
Yeah.
their risk for complications, non-healing, wound drainage, infections go up. So these are things that we want to, we want the patient to have the best outcome possible.
Yeah.
And so if there's something we can modify, we want to do that before putting a patient through the risk of a surgery.
I mean, I guess if you think about it, it's an investment in yourself.
Yes.
So, I mean, there's a lot that goes into it
Yep.
beforehand and after.
Yeah,
so.
and there's a lot of people that we've gotten to stop smoking.
Yeah.
And they're like, Dr. Smith, I'm doing great after my surgery, but you know what? The best thing was I stopped smoking. I feel
Yeah.
so much better now that I stopped smoking.
Yeah.
And so I've heard that time and time again.
Wow.
So,
Kudos to people who can do it, and it saves you money.
Yeah.
So, a good move. Okay, again, I have to look over here because I can't read the other monitor. So, we had somebody who called in, I think it was Wesley, and wanted to know what is the treatment for arthritis in the back, and how common is leg pain in the front leg from the back? So, if you'd have, I guess, could you have leg pain that was associated with your back?
So I can actually kind of show here on the model. So what we get when we get arthritis in the back, either the discs can kind of wear down, but ultimately the arthritis occurs by these joints here in the back. Okay, and so as these joints get arthritic, they start to get bigger. If you've ever seen anything like a patient has an X-ray of their hip and they start having big bone spurs and things like that, the bone spurs then grow in the canal where the nerves are.
Okay.
So the space for the nerve becomes much smaller, starts to pinch the nerve and starts causing pain down the leg. Okay.
All right.
The most
So
common
it's like a pinch nerve. Pinch nerve.
Yes.
Okay.
The most common levels are these kind of bottom levels here. So L4 down to S1. Typically, those will cause pain down the back side of a patient's leg.
Okay.
As we move higher up into the spine, it can kind of start to cause pain in the front of the thigh or into the groin.
All right.
Another common thing that can cause groin pain or front of the thigh pain is hip arthritis. So those two kind of things sometimes start to kind of mimic each other, and that's when we need to do appropriate physical exam and kind of take a little better history and to kind of understand what's going on.
Right.
So those are the two most common. It's either hip arthritis or arthritis from the back.
Now, and I will hear people who have that nerve pain. I think, do they do epidurals? They used to, I used to know somebody who would get one like every few months.
Yeah.
But I mean, at some point, is it futile to keep doing that, or could that be a long-term solution?
Yeah, I tell people you get 2 or 3 injections a year and you do great with them.
Yeah.
And if you avoid a surgery, especially if you need a big surgery,
Right.
that's great.
Okay.
Again, it's some people are like, at some point they just kind of get tired of getting the shots and they want something that's more permanent.
Yeah.
But again, depends on your risk factors. Depends on how much it's affecting your life. So
Right.
there's a lot of different things that go in with that.
Sure. All
So.
right. Well, while we've got the model right there, the next question was, in particular, it was Karen calling, and she wanted to know if you could point out where T9, 10, and 11 are on there. And I think there was a second part to her question, but I'm not sure. I don't see it on the screen. Oh, she wants to know what could possibly cause that to collapse on the spinal cord.
Yeah.
Is that something that happens?
So what can
or?
happen is it won't be the disc that typically collapse, causing issues on the spinal cord. The disc can collapse, and at T9, 10, 11, so this is kind of L5, 4, 3, 2, 1, 12, 11, 10, 9. So it's kind of be right in here.
Right
so
in
it's
the
kind of the
section.
mid back.
Yeah.
Okay. And so yes, it can, if people have bad arthritis or if they have a big disc herniation that comes from the disc, in the front, it can kind of start to pinch the spinal cord. And so it can start to really kind of narrow that space around there.
Okay. How do you address that then for treatment?
Yeah, so it depends on if it is more arthritis is coming from the back of the spine versus if it's a disc herniation coming in from the front.
Okay.
That kind of dictates what type of surgery it would be. Typically though, if patients have impingement on the spinal cord, so anywhere in the thoracic spine, they're actually having typically issues with their balance. They can't walk very straight.
Okay.
Sometimes they have just kind of global numbness of their legs or their feet. And that can be hard to delineate between if it's neuropathy or if it's a spinal cord issue. And so that's one of our jobs of making sure we get appropriate imaging of the spine, getting a nerve test to see if it is neuropathy, and there's some physical exam things that we can check too to kind of see if there's pressure on the spinal cord versus something else.
Yeah, that sounds really miserable though too, to have that kind of
Yep.
pain. I would imagine that's pretty bad.
No, absolutely.
All right. Well, thank you to everybody for all the questions, and we actually have some more. Let's see, Stephen called, or I guess, is Jill still on the line? I guess, okay.
Yes, I'm here.
Okay, there you are, Jill. Thank you for your patience. I wasn't sure if you were still there. You wanted to ask a question about, was it lower neck pain?
Yes, I've got musculoskeletal neck pain. It says M54.2. It says osteoarthritis of cervical spine, unspecified spinal osteoarthritis complication status. Is there something that can help relieve the pain that I get on the lower right side of the back of my neck because of the osteoarthritis of the spine, of cervical spine?
Yeah, so great question. So a lot of times, you're going to have some muscle pain and also pain from the joint, kind of like down in the lower part of that neck there. Typically that's anti-inflammatory medicines, maybe a muscle relaxer. Sometimes we talk about a steroid injection, so we can do a trigger point injection just real quick in the office into that muscle that may help calm it down. and then really work with physical therapy on that area. Sometimes if it's causing a bit deeper issue, especially if it's going down to the arm, then we may talk about an epidural. And if it truly is the lower part of the cervical spine and it's causing that pain or numbness and tingling, things like that in the arm, eventually after you've kind of gone through that whole gamut, then we may discuss a surgery if it's appropriate. But those are kind of the early things that I would talk about. You know, it's hard, that area right at the base of the neck, it's the transition between your mobile cervical spine, you know, we're moving our necks, and then our thoracic spine, which is very stiff and stout because you have the rib cage and everything. So it's a transition from fixed to mobile, and so a lot of people end up with some pain there, and it's just, you know, it's just a consequence of kind of the design of our bodies.
All right. Jill, did you want to ask Dr. Smith something else?
Yes, I was wondering how effective do you think the physical therapy is, and also do you have to go through about 6 weeks of that before you can get a cortisone injection?
So usually we can do a cortisone injection pretty routinely and easily in the office. You know, we'll call a trigger point injection into that muscle. Physical therapy does really work well. I see people all the time, you know, they come in, they're like, oh, I'm so surprised of how well physical therapy worked. So there's a lot of things they can do to kind of help calm that inflammation down, get the muscles relaxed, especially if it's, you know, when people wake up and they're like, oh, I have, you know, a crick in my neck, and then 2, 3, 4 weeks later, it's still there. And if, like I said, if it's not going down the arm, then it usually is just, it's more of a muscle or an arthritis flare. And so that's really where we're trying to work through all those things. And then, yes, if it needed, then we can do a deeper injection, epidural, which the spine interventionalists do, or are also known as pain management specialists.
All right.
All right. Well, thank you for your time tonight. Thank you.
You're welcome. Absolutely.
Thank you,
Bye-bye.
Jill. I hope you're feeling better. Thank you for calling. I know she was talking about physical therapy as if it was kind of a downer, but it can be fun. I mean, I don't know if any of you watching have had physical therapy. My daughter had to go a lot this past year for some back issues. They are some of the happiest people. Yep. I mean, they post jokes. Each day, like, they wear different colors. They play different music depending on what. I mean, some people will schedule their physical therapy because they want to be there on country music day, you know, versus, you know, the 80s, you know, rock songs from the 80s. Yeah. So, you know, I mean, if you think about it, it's kind of a bummer that you have to go. And sometimes I saw some people who were in a lot of pain, but I think they try and make the best of it.
No, they absolutely do.
Yeah, we have made a lot of good friends doing that. So.
Yep.
Let's see, I do have one more question for you, and this was a gentleman who called it in. So Stephen wanted to know about his wife because she has a lower fusion on 3 and 4 in her lower back. I guess her screws had become loose, so he was wondering, is there a minimally invasive surgery that can repair that? Yeah,
so some of it depends on how loose they are, if there's any other deformities of the spine or anything like that. Especially L3-4, there's some minimally invasive techniques that we can actually do where we can access the spine instead of going back in through the back. Sometimes we can actually come in through the side through about an incision like this, and we can kind of just split the muscle, and we can kind of come in to the disc space here. This would be L3-4 right here, and we can take this disc out, and we can put in what we call it a cage, but really a cage is just, it's an empty box that we fill with bone graft, and it basically kind of fills and takes up that space of the disc. So people think of a cage that's like a fence, like you're wrapping the spine. It is not like that. It's just literally a box that then kind of comes in, and we'll then get that area to fuse. And then, depending on what it's like, you know, we could still make a couple small incisions, take those screws out and put new ones in, but it also depends on how much bone's worn away from the loose screws and things like that. But there are definitely usually some options, especially at L3-4. That's one of the easier levels to repair in a minimally invasive fashion.
I was going to say, most people probably want to try and, if you go through a pretty major back surgery, you probably want to avoid anything major in the future. I mean, most of the screws and the hardware you use, are they typically, I know you've brought some things on before, and I couldn't believe how heavy and solid they were. I mean, they're built to last.
They are.
Yeah. Yeah,
they're usually strong titanium.
Yeah.
Between the rods and the screws is the most common metal we use.
Do they put a year on it? Like, is there ever a guarantee like, oh, these will definitely last for 10 years? They won't do that. Okay. No. I didn't know if they give you a ballpark promise like that. So, all right. We only have about 30 seconds left, unfortunately, but I do want to thank everybody. I know the show always goes so fast. It flies by. We had wonderful calls tonight. Thank you so much to everybody for calling in, and many, many thanks to Dr. Smith. I'm sure he's got a very busy schedule, and we appreciate him giving us this time once again. So we will have another live show coming up next week, and Mark Evans will be hosting that one. So please tune in for that next Tuesday evening. In the meantime, I'm Jennifer Blomquist. Take care. Have a great rest of your week. We'll see you next Tuesday.
PBS Fort Wayne was made possible in part by
Momentum, progress, innovation. Parkview Health knows standing still isn't an option. We must learn, grow, excel, and actively work to advance healthcare for our community and beyond. With technologies that improve access to care and teams of specialized providers, we are moving healthcare forward. Right here at Parkview Health.